Pediatrics upper airway is going to engage some of the infectious disease of the oropharynx. And you're going to see how closely these diseases relate to each other. I do not mean to imply that when you see one on the wards, they're going to be so similar that you're going to get confused. I do mean to imply that when someone writes a test question, they're going to include lots of buzz phrases that are going to end up being in all of them. So you have to be careful and hone in on the very specific things that allow you to get the right answer. 5 diseases. So let's start off with the most common and use that as our backbone. And that's going to be croup. Laryngotracheobronchitis. Croup is an infectious disease. It is caused by parainfluenza. It is going to affect kids generally in the 3 months to 3 years range, young kids. And what happens is they get infected with croup and they'll have a viral prodrome. It'll be just like every other virus they've got, and that will progress into, and this is what you're looking for, a barking or seal-like cough. And in between these coughing spells will be stridor, an inspiratory wheeze. It's the barking and the seal-like cough that you're trying to hone in on, because that's going to be the thing that's classic for croup. Right, now you could do an x-ray. What you'd see is subglottic narrowing called the steeple sign. But the steeple sign is, for one, neither sensitive nor specific, and as you'll see, it appears again in a different disease. Not useful. Instead, what is your clinical syndrome. You're going to identify croup as croup. It looks like croup. In fact, the patient might even get better as they leave their house into a cool winter air. That's a good sign that you probably have croup. What you're going to do is actually give them racemic epinephrine. And there should be an improvement in their overall condition with racemic epi. That's the diagnostic step. The treatment goes something like this. If it's mild croup, and they didn't really need to be in the hospital at all, that is, they probably didn't even need to come to the ER to begin with, you just give them some misting and send them home. If it's moderate, well, here you want to treat them. You're going to give them racemic epi, steroids, generally in the form of IM, and oxygen supplementation as long as they need it. Severe croup does happen, and these are the people who get admitted for ongoing oxygen administration and continued racemic epi. So it's going to depend on how severe it is. Now, this disease is going to be compared against bacterial tracheitis. Bacterial tracheitis is almost always caused by an infection of Staph aureus. It usually follows a viral prodrome. And there's a wide range of kids who can get bacterial tracheitis, the average being about 4 years. So it's in the same age bracket as croup. And it's a little more indolent because they have a viral illness and then they get over their viral illness and then they get super infected with staph and it takes a little bit of time to get worse. But for the most part, what you're going to expect to see, especially on the vignettes, is croup. You're going to see croup that does not improve. You have the seal-like barking cough. You said, I know this is croup. Give him some racemic epi. Give him some steroids, see what happens. They don't get better, though. And because it's a bacterial infection, they may have slightly more toxicity. That is, higher fever, higher leukocytosis. Say, okay, hang on. This is not going well. Maybe I need a diagnostic step. Well, if you got the x-ray, you'd see subglottic narrowing, which is the steeple sign, which is why I say don't even bother with it, because the lateral films aren't going to help you differentiate one disease from another. They're not sensitive, they're not specific, and it's the same sign for 2 different diseases. But what you did was you tried racemic epi, so it didn't work. It didn't get better when you tried racemic epi. And now you're thinking, okay, something else is going on. If they're a little more toxic, they're not getting better with racemic epi, maybe they don't have a viral illness, maybe it's bacterial. And then you're going to do a tracheal culture, because now you're trying to identify the bacterial organism. And you're going to treat the person with IV antibiotics. You may get your friendly ENT in there to do some sort of scope, laryngo, pharyngo, broncho, something, looking for any purulent material that they can culture. And if they see purulence, then you're even more likely to give IV antibiotics. It's really hard to see in the trachea with your own eyes without a fiber optic scope, so you need a specialist to get in there. The third disease that's often compared against these two is epiglottitis. And we keep teaching epiglottitis because it is a fatal disease. Good news, the incidence of epiglottitis has plummeted in the past 10 years because it's caused by H-flu. And since we have a vaccine against Hib, we no longer have any problems with getting epiglottitis. In fact, the pathophysiology or the epidemiology has shifted so much because we're not really sure now who's vulnerable. In fact, the people who get epiglottitis now are in their 50s, not kids anymore. And so the age group has shifted a little bit. It's going to be a little bit older, 3 to 7 years old, especially if they give you a history of not having a vaccine, you're done, it's epiglottitis. But the person who has epiglottitis doesn't have a barking seal-like cough. They are sick as shit. They have a rapid onset, high spiking fever. They're going to be tripoding, drooling because it hurts to swallow. They'll be using accessory muscles. And if they try to talk, it'll be with a hot potato voice, also called a muffled voice. You'll see how useless that becomes as well. It's all of that put together, right? Their epiglottis is swollen. There's not a lot of room down there. And they're trying to keep their neck open as best they can to keep their airway protected. And if they swallow, it hurts, so they're going to drool and have secretions all over the place. Now, you could get a radiograph. Try to do an x-ray. The x-ray is going to show you a thumbprint sign. Well, you shouldn't have wasted your time with the x-ray. If you've got this clinical picture and they're not vaccinated, you need to make the diagnosis in the OR. That is, your primary goal must be to secure the airway, and you do that in the OR. So you will visualize the cherry red, swollen epiglottis while you're securing the airway. And that is to say, the treatment is get the airway. You get an endotracheal tube in the OR with an anesthesiologist and an ENT at the bedside. Right? This is not something you muck around with in the ER, because if you poke that epiglottis and it swells, you've lost the airway and you need to crike somebody. And then after securing the airway, IV antibiotics. Well, epiglottitis gives us access through that hot potato voice and sick as shit appearance to talk about retropharyngeal abscess. The retropharyngeal abscess is going to be caused by oral flora primarily. But you can also consider some of the bugs that cause upper respiratory tract infections. The patient is going to be sick as shit with an abrupt onset, high spiking fever. They're going to be drooling. Their neck is extended. They usually have neck stiffness. And they're going to be drooling with a hot potato voice, also called muffled. It sounds an awful lot like epiglottitis. Well, how do you differentiate the two? Well, a retropharyngeal abscess is going to have an abscess, and this is the thing you want to latch onto. What you're looking for is the anterior chain unilateral lymphadenopathy. And you're also looking for the tender mass that is the abscess. So feel the difference. In epiglottitis, they're barely able to keep their airway open, drooling all over the place. In retropharyngeal abscess, you're like, oh, this could be epiglottitis. Oh, look at this giant thing over here that I push on and it hurts. That's the abscess. Make the diagnosis, you don't have to rush them to the OR. Get a CT scan. And being an abscess, of course, you want to drain it. So, incision and drainage, or an aspiration, however you decompress the abscess, and then you give IV antibiotics. Retropharyngeal abscess then gives way to talk about peritonsillar abscess. And peritonsillar abscess is also caused by the oral flora, but it can be the upper respiratory bugs. And the patients are going to be older. Right? This one's way different than the rest. It's generally going to be an adolescent. That adolescent is going to have a hot potato voice, also called muffled, which is why I don't want you to focus on hot potato voice. That's just going to distract you. This person is going to also have a sore throat. They've got an abscess back there, so they're going to be drooling, have some dysphagia or odynophagia. But the thing that separates it apart, other than the age, is the fact that they've got uvular deviation. And sometimes you'll be able to see the swollen tonsils shifted over. So that's pretty easy. You actually just look in their mouth and you see it. Hey, the uvula is shifted over. That's the only one that does that. The diagnosis is clinical. You start IV antibiotics and get someone to drain it. So I want to back up and just talk about this from a bird's eye perspective. Croup, barking seal-like cough, given racemic epi. That doesn't work. Think about bacterial tracheitis, try some antibiotics and get a look at the back of their throat and see if there's any purulence. If they come in really sick, barely able to keep their airway open, and they're not vaccinated, get these kids to the OR. Secure the airway. If it sounds like it could be epiglottitis, but they're really not selling it, and they've got something on their neck that's tender and some lymphadenopathy, get a CT scan. If you look in the back of their mouth and you see the uvula is deviated and they've got this big thing sitting on the side of their neck, it's peritonsillar abscess, no imaging required. Also the theme, no imaging required except the oropharyngeal abscess. X-rays don't help you. And so I hope you can see now that upper airway has a lot of crossover, but if you hone in on the things that you need, it becomes a lot easier to keep these diseases separate. That's pediatrics upper airway.